This is something that is so shocking that this is what we don't learn about our bodies when it comes to health class or even the basics of sex ed. Because your menstrual cycle is that ultimate sign that at least some of your reproductive hormones are functioning appropriately. And there's so much misinformation and social media chatter. Your menstrual cycle is a communication between your brain, your ovaries, and your uterus. And all these parts are working together. I always like to say that your hormones are a messenger system only. It's like text messages that your brain sending to your ovaries, sending back to your brain. Nobody really knows what's happening. They're relying on the messenger to tell them what's happening here. And so that can give you the idea that there's a lot of reasons why things get missed. You missed your friend's text message, service was down. The same thing can happen within our body as well. But if we think about if everything is functioning perfectly, this should be a very predictable cycle. I always say your period should be so regular and predictable that if I put a calendar in front of you, you should be able to put your finger on the day of your next cycle and only be off by 1 or 2 days.
Well, Dr. Crawford, I just so appreciate your time being here with us today. You are a wealth of knowledge, someone that I turn to when I just want to look something up. I mean, you have so many resources out there for people as well to learn and be able to understand their bodies in a way that I don't think we are as connected to or understand, especially in the age of where we are in fertility and, you know, so many of our friends are in this stage. So I really appreciate your time being here.
Well, thank you guys so much for having me. And I'm so honored to spend this time together and just facilitate this discussion more, because it's something I'm just really passionate about, that people can understand their bodies better and be better advocates for their own fertility, their health. Just in general, we've done a bad job as a society helping people understand what's normal, therefore what's abnormal.
Exactly.
Yeah. And kind of like Jen said, I mean, this isn't something people are super connected with, and it doesn't become something that's important until you're struggling to conceive or until you're thinking about having a child. That's like the first time that fertility often comes into people's minds. And I know I've heard you talk about fertility as a real, like, important biomarker of our general health anyway. So can you explain why fertility is such an important health marker that people should be aware of always?
I love that you're bringing this up just from the beginning, because I think what you said is so true. Very often, we don't think about our fertility until the moment's in front of us. In fact, we do the exact opposite. How do we prevent a pregnancy? Prevent. And then suddenly, oh, I want to get pregnant. Now what? And if we step back and we think about what your fertility really is, it's a sign that your hormones are functioning normally. It's a sign that your body is in a good state in the place that it can get pregnant. And there are so many different diseases or situations that can impact our fertility. And these all make it so that fertility is actually a health marker for longevity, for chronic medical illness. The harder you have a time getting pregnant, it might make you higher risk for certain diseases later on down the road. When we think about these diseases, things like metabolic syndrome or heart disease, even things like stroke or long-time mortality. I know that sounds really scary and it can feel very blamey for somebody who might have infertility. But I always like to just say, really what's connecting the dot here is this idea of inflammation, meaning it's not just coincidence that somebody has a higher risk of having a heart attack if they had infertility. There are certain underlying processes that are at higher risk in both of these situations. And a lot of this has to do with inflammation, some of which we can control and some of which we can't. But it is something that people are not talking about. And that's why we know that starting to think about your fertility as your health. I always say what's good for your health is good for your fertility. They go both ways. That's really a great way to reframe it, because we know now we're having more attention to fertility, but also to perimenopause, to menopause, to longevity. Yeah. And a lot of this is really tied to the idea of how long can we have our body functioning in the best way possible.
I mean, laying that foundation, I think, is so important and so great to even just jumpstart into this conversation. And I want to start also with the menstrual cycle, because this is where we start to understand as women what's going on in our bodies and maybe starting to identify what's normal, what's abnormal. So can you kind of talk us through what a normal functioning menstrual cycle should be and what the hormones are kind of doing?
this is something that is so shocking that this is what we don't learn about our bodies when it comes to health class or even the basics of sex ed. Because your menstrual cycle is that ultimate sign that at least some of your reproductive hormones are functioning appropriately. And there's so much misinformation and social media chatter. And I've had patients fall down the very wrong pathway when it comes to this. So I love the question. Let's think about it. Your menstrual cycle is a communication between your brain, your ovaries, and your uterus. And all these parts are working together. I always like to say that your hormones are a messenger system only. It's like text messages that your brain sending to your ovaries, sending back to your brain. Nobody really knows what's happening. They're relying on the messenger to tell them what's happening here. And so that can give you the idea that there's a lot of reasons why things get missed. You missed your friend's text message, service was down. The same thing can happen within our body as well. But if we think about if everything is functioning perfectly, what happens is at the start of the month, I always like to explain that I envision women have all their eggs kept in a vault inside their ovary, and they're there your whole life. Every month you have a group of them that comes out, and eventually you'll be out of eggs, and that will be menopause. But if we look at a singular month, you'll have a group of eggs all come out of the vault. Each egg grows inside a follicle. The egg is microscopic, but we can see the follicles, and they're actually well named because what happens at the same time, the brain's going to send out FSH, follicle stimulating hormone. So a well-named hormone that's going to get a follicle or an egg to grow. And as that egg is growing, it's going to make estrogen. So the first half of your cycle is considered the follicular phase, the phase where a follicle is growing. It's a well-named phase. Your cycle starts with day 1, which is the day you actually start your period or your menstrual. So when you're bleeding, that's the start. Officially, menses, we consider your period. It's actually the first part of your follicular phase. Very often we talk about the cycle, we act like it's your own phase. You'll hear people say there's menstrual and then follicular. I think it's important to say it's actually one and the same. But we know when our menstrual cycles, we know when we're bleeding, we know when our period's happening. But what's happening is as that follicle starts growing and making estrogen, it is the rise in estrogen that stops us from bleeding. So that helps you understand that it's really the start of that phase. When that estrogen gets to its peak level, suddenly the brain gets that text message over and over and says, we must have a mature egg. I see so much estrogen. And it's actually a very specific amount. It's like 200 picograms for 50 hours is the amount you need to tell the brain an egg is mature. And at that time, the brain will send out a surge of LH or luteinizing hormone. And LH will cause the follicle to rupture. The egg will be released. And then the follicle will reform. And with that follicle being reformed, it will start to make then progesterone and will be entering into the luteal phase or the second half of the cycle. So the phases of the cycle are really named based on what's happening in the ovary. Is it a follicle growing an egg, or has it turned into a corpus luteum that's now making progesterone? The luteal phase is where it's defined by having progesterone. But I think a couple really important points is that we don't have a steady state of progesterone. Unlike estrogen, where it was constantly increasing in the follicular phase, in the luteal phase, our progesterone is made in pulses because our brain sends out LH in pulses. So you have a raise and a fall of progesterone throughout the entirety of the luteal phase. Estrogen is still made, but there's no magic estrogen to progesterone ratio here because it just depends on where you're checking in regards to an LH pulse. But there is progesterone present. The corpus luteum can only live for about 2 weeks. So it will then die. Your progesterone will drop, and that will be the signal to your uterus to start bleeding, and the cycle will start all over again. So estrogen grows the lining as the follicle is growing, talks back to the brain. And that follicular phase is an estrogen dominant phase, meaning estrogen only, no progesterone. And then after ovulation, you have both estrogen and progesterone. But progesterone is such a profoundly impactful hormone, meaning we really feel when we have progesterone. It is the progestational hormone. Its goal is to make you sit on the couch, avoid dangerous things, save your energy and your calories, get ready to gestate a baby. And so we often really feel these symptoms of the luteal phase in that time period. And so this should be a very predictable cycle. I always say your period should be so regular and predictable that if I put a calendar in front of you, you should be able to put your finger on the day of your next cycle and only be off by 1 or 2 days.
This is where I don't think that people are even aware of what's happening, what they're feeling, what they're doing to be able to even predict, right? When the next one is happening. And then there's so many symptoms that come along with most periods that people, so much is talked about as normal. So I want to ask you, what is normal? Is it normal to have so much cramping and pain every single period? Are we not supposed to feel when we have a period? Are we supposed to feel when we're ovulating? I know some women have said that they can feel when they're ovulating. And so what is normal? What is abnormal?
So we think about normal cycles. We want to think about regularity. So we kind of already covered that.
Yeah.
And then two factors you're touching on, which is really pain. And then I'll add in like bleeding as you're bleeding normal. So when it comes to pain, it's not uncommon to have pain. If we think about physically what is happening, your uterus is a muscle. It is contracting to expel the endometrium or the lining that is hormonally responsive that grew in that past cycle. It wants to shed that and have a fresh foundation for the next month. So it is contracting, and most of us do feel pain or cramps when we're having uterine contractions. However, it should not be the type of pain that would prevent you from your quote unquote activities of daily living or from fun things. If you have dinner plans at your favorite restaurant and you tell your partner, I don't want to go because I'm on my period, that's not normal. If you call in sick to work, if you are an adolescent or back when you were younger, if you were missing school, things that could be fun activities, you'd cancel plans with friends because of your period, that is to a level that is not normal and can be really concerning for a few different conditions. Some of them that are most concerning are endometriosis or uterine fibroids or adenomyosis. These are all pain-related conditions that we don't know people don't know much about at all. The worst thing about pain and female pain in general is it's been dismissed for so long. If you told your doctor you had pain, so many women had the shared experience of being told that's normal, just deal with it. They get gaslit and then they gaslight themselves, essentially saying, I must be weaker than everybody else. I just don't tolerate my period like my friends. And they convince themselves that something's wrong with their reaction to the pain instead of listening and saying, this pain is actually a problem. And it's my body trying to tell me that there's some underlying process going on that could be impacting my health and, my fertility long term as well. Similarly with bleeding, your bleeding should happen when it comes to your cycle. You might have a day or so of spotting before or after, but prolonged spotting before or after is not normal. And then spotting or bleeding intracycle, so not when it comes to your actual period blood, but in between, should not be routinely common. And that can represent other underlying factors or structural abnormalities or hormonal issues that could be going on. So it could either be a polyp in the lining that's preventing it from compacting, or it could be a hormonal problem where the luteal phase isn't as strong. Often you may not know what's going on, but it's your job as a woman, as a patient, to know, hey, that's not normal. I shouldn't be spotting for a week in my luteal phase. That's a big red flag again that something's going on. And you asked about ovulatory pain, which can be common. Now, what's interesting, if we think about just the inside of our abdominal cavity in general, the peritoneum is very poorly innervated, meaning your brain has a really hard time saying, that's my ovary, that's my appendix, that's my intestinal tract, until you've been made aware that something's there. So for example, women who might have gone through IVF before, later are often a lot more in tune that that's ovarian pain because their brain has connected the feeling to their ovaries. But your ovary is growing. You heard me say when we talked about the menstrual cycle, a follicle is going to rupture. Essentially, that's a cyst that's going to burst and the egg is going to come out of it. And that, of course, can be a painful process. You'll have a little bit of free fluid released into your abdominal cavity. And depending on where the follicle chooses to rupture, you can have some bleeding as well. So it's not uncommon that ovulation could be painful. It shouldn't be routinely debilitating, but it even has a name. It's called Mittelschmerz, which is German for in the middle, that pain that's in the middle of your cycle. And if you're feeling it, that is when you're ovulating. So some people have the best internal clock about when are they ovulating or tracking their cycles if they do in fact feel that ovulatory pain.
That's fascinating.
And then, talking about all this, and you mentioned the gaslighting that people can go through, or, oh, yep, that pain's normal. I feel like this is when we start to tip into people being told oh, you just need to get on birth control to get rid of that. And then this might help tip our conversation into the fertility side of things and where that might pose some problems or issues down the road when people do want to eventually conceive. So can we talk a little bit about use of birth control to mask or get rid of these legitimate pain symptoms that are probably trying to tell people that there's an underlying issue, but instead we just mask them? And how does that down the road then potentially impact fertility?
You hit the nail on the head with this one. And I want to say hormonal birth control, or as we talk about it right now, when we say birth control, we're going to talk about the combined birth control pill, which is both an estrogen progesterone pill, because that's what most of the time we're referring to. Birth control has some legitimate medical uses. So there are places where some people will highly benefit from birth control. We use it sometimes in the fertility spectrum, and it also is a very effective form of contraception. So we're not trying to scare anybody away from using their birth control, especially if it is working for you. My biggest issue is that a lot of hormonal or pain issues might get better with birth control, but especially in our generation, we had women going to the doctor, complaining of a symptom, and being put on birth control without ever having a diagnostic evaluation done. And maybe that was the right treatment, but you owe it to yourself, or you deserve knowing what's going on. So it's one thing to say, we had blood tests and an ultrasound done. I found out I have PCOS. I know this might impact me long term, so I'm going to start to make XYZ lifestyle changes. And I'm going to get a fertility evaluation done sooner because it may be an issue. However, birth control is a great treatment for me right now because I don't want to conceive yet. And I'm going to feel comfortable on the pill because I know what we're treating with the pill. It's very different than the generation of women who were put on the pill for irregular cycles, heavy bleeding, painful bleeding. They had no idea anything was ever wrong with them. They stopped the pill, and then they started having all these cycle abnormalities. And what we also see on social media is a blaming the birth control pill for causing the cycle abnormalities, which is also false. Your body is now reverting to its baseline, which is what got you into this situation to begin with. You just never got that opportunity to understand what was really happening, learn about your body. Think about all the years somebody with PCOS could really learn about that disease. They might proactively get off the pill sooner and see what their ovulatory status is doing. So we've taken away that autonomy about understanding your body by this reactionary, let's give you birth control pills for that. And it's not just physicians who are at blame. I mean, it's really the healthcare system, right? We see that, women go in for a 15-minute appointment. They have to get a pap smear, all their preventive care done. If you bring up your issues, your doctor's trying to help you, and maybe insurance doesn't cover all these tests and you can't pay for them out of pocket. So I don't ever want to be in the position of doctor blaming, even though there are some bad doctors out there. It's really a byproduct of how US healthcare is and the situation that we are in. But I think this is why your doctor might make certain assumptions that you don't want to spend the money, or that the answer doesn't matter because you're only 24 and you don't want kids for a while. This is where we have to come to the table and say, are there tests we can do to see what the underlying cause is? I'm not opposed to the birth control pill, but I'd really rather see if we can get to a diagnosis first and then make sure this is the right treatment. And we really have to be a self-advocate, which I don't love, but it's the reality of today's society.
Yeah. I mean, that's a great way to put it. And I think there has been a lot of fear when it can be a useful tool. But like you said, understanding the root cause first and understanding our bodies gives us so much more autonomy and empowerment back into what we can do in next steps and what we utilize in lifestyle alongside of that. And I think that's what often gets missed, right?
Completely. And I've seen patients who really could have benefited. We'll use an example, a PCOS patient who has highly irregular cycles has now seen such a whiplash on how social media might approach birth control. They are refusing to be on it. They don't really understand their disease. And I've seen women develop endometrial cancer because they're not having periods, because it's a known, consequence of PCOS if we're really not having cycles that could have been prevented had they been on the birth control. So a lot of it is patients not being given the opportunity to get to a diagnosis, educated on the why. A lot of people, I always tell my patients, I give you the benefit of the doubt that if I explain something difficult to you, you're smart enough to take the information and make a choice that's right for you. And so, that's a great point that you have, is that we have so much birth control pill blaming. And it's not that the pill doesn't have its side effects. It is a pro-con conversation that needs to happen. But I see a lot of patients who could benefit from it who are scared. They are now scared that it's going to hurt their cycles, cause infertility, make something harder for them, that there's no truth in that. And I think we have to really make sure we're dissolving that myth.
Yes.
It's very similar to the conversation we could have about most medication in the United States for most conditions. I mean, you think about like diabetes, like how much education and information and opportunity are we giving people living with type 2 diabetes to do behavioral management alongside use of the medication. So definitely something that always should be inserted that potentially isn't in many situations.
You're so right. It's really across the board. And it's funny because I'll see patients say, oh, I don't want to be on hormones, but there's so many hormones that people are fine being on. And it's just really kind of a negative connotation that has been attached to reproductive hormones or birth control in general, because people haven't been given the opportunity to be made aware of what they are and what they aren't, or to learn about their own body or how to take charge of things from a lifestyle standpoint. And you can't cure everything with lifestyle. That's what I always tell patients. But a lot of what we experience is a sum of every choice you make, right? And every little choice in the right direction actually can add up and be very impactful. So it's not one of those situations where we want to be like, throw the baby out with the bathwater. I'm not going to do all that stuff, so I'm going to do none of it. It really is a comprehensive approach to our bodies. We have to understand what's going on, try to get to a root cause, and control the factors that we can without being afraid of modern medicine, because certainly for some diseases, there are ways that technology and medicine can help that nothing else can. And we have to know that both things can be true at one time.
Exactly. I think this is such an important conversation. And I love the way that you're interweaving yes and, right? It all gets to be part of the conversation. Now, when someone is thinking of trying to conceive and they've been on birth control, is there a certain time that they should be thinking of starting to get off? Because there is the fear of like, well, if I get off, will I get pregnant right away? And I'm not ready to. But at the same time, there's a fear of like, well, what if I wait so long and I'm wanting to get pregnant now? So is there kind of a sweet spot that you recommend?
Great question. I do think a little of it depends on history and goals. So number one, to the point that you made, birth control pills, they wear off very fast. There's this idea that it takes months to wash them out of your body, or you have to buy a cleanse for your birth control. And none of that's true. We know that if you skip even just one pill, theoretically, you can have an ovulation escape and could get pregnant. So birth control is very short acting medication. So if you're going to make the decision to stop your pill because you want to track your cycle and see what's happening with your body, which I'm a huge proponent of, you need to use a backup method of contraception. So whether it's condoms are probably going to be the best thing in this scenario because you haven't been able to track your cycle. So I don't love somebody coming off of birth control and saying, I'm going to use natural family planning and cycle tracking to prevent a pregnancy right away because, well, we don't know what your cycle is. Exactly. Mm-hmm. When it comes to how long should you come off, a little bit of this is how long have you been on and how have you been taking the pill? If you've been taking the pill where you still have a bleed every month because you're either taking the placebo pills or you have those placebo pills in your pack, you're bleeding every month, then probably 3 months before you want to get pregnant is a good time to stop the birth control pill. This is going to allow you to have a couple cycles to say this is regular. And if you haven't had a period back by that time, or you've had a very irregular couple of cycles, high alert to let you go in and start to get an early evaluation. The recommendation is a little bit longer if you've been taking continuous birth control pills. Now, I love continuous birth control pill, meaning if you don't want to get pregnant, you can take an active pill every single day and you don't have to bleed at all. I mean, that's fantastic. It helps prevent anemia. A lot of people have a very constant, steady state hormones. When you're giving somebody hormones, you don't have to have a bleed. So in this circumstance, a lot of women love these. I have a bleed every 3 months, every 6 months, or not at all because I'm constantly taking an active pill. But the caveat here is that daily progesterone exposure thins the uterine lining to a place that might take months to recover. Same rules apply if you have a progesterone IUD or if you had a progesterone implant, because that really prolonged progesterone thins out the lining. We always hear about people with progesterone IUD like a Mirena who said, I've had no periods for 5 years. It's been amazing. I believe it has been amazing. But we really want to give that uterus some progesterone time or some time away from progesterone to have the lining regrow. So in those circumstances where you haven't had a bleed in a long time and you've had daily progesterone, I want 6 months before you want to get pregnant, because your ovulation might be back and fine, but the lining might be so suppressed from that progesterone that it's not thick enough to actually bleed. And the bleed is our outward sign that everything is happening okay. So I think that that's a little bit longer. And if you're really not ready to be pregnant, you have to take that with a grain of salt and really make sure you've got a good game plan here. If you're okay with condoms, or if you did get pregnant, is that a okay time frame? This is where I wish more couples fell into the, hey, we're not trying, but we're okay. We're not preventing, right?
Mm-hmm.
We're not trying, but we're not preventing. We're okay if we get pregnant. Many people don't start that until they're actually just having unprotected sex, right? That is actually trying. With this is the, hey, we're using condoms. We are okay if we get pregnant. Maybe we're not perfect with condoms. It's not the end of the world, but we're not really trying yet, because unprotected intercourse is trying to get pregnant.
We're coming off the pill, right? And this is where, like we've mentioned, a lot of people start the whole, okay, what do we do to get pregnant? And the panic if you don't get pregnant quickly. And so can you give people a better understanding of what should go into this process of training to conceive? What can both partners be paying attention to help optimize that opportunity and optimize the chance? And how long is normal to, for it to take to get pregnant?
I have a whole book coming on this exact topic. So we're going to try to answer it really concisely in one sentence or in one little thought. So I think a few different things. Number one, if you're ready to get pregnant, let's make sure a few checks and balances before you do. So we talked about stopping your contraception if you're on any. We want to make sure we're taking a prenatal vitamin with folic acid. We want to make sure that if we have any medical problems, like medications we're taking, that those are safe in pregnancy. And we want to start looking at our lifestyle to optimize what we should be doing to get pregnant. What is healthy for your body, is healthy for eggs, healthy for sperm. These factors, there's what's good and bad, and then there's also what's optimal, right? And I think we have to kind of think of it both ways. So we know that alcohol, marijuana, smoking cigarettes, exposure to lots of plastics and toxins. We know a lot of these things, quote unquote, are bad and they can harm us. There's some neutral things or things that we know are good, but then there's things that are really optimal. So in this early stage, I say at a minimum, we want to avoid the bad. Things that we know hurt our fertility, hurt our health, could hurt a pregnancy. Those things we really need to be taking out of the equation or minimizing. So it's going to be those toxins, both environmental toxins or substance toxins. It's going to be diets that have high and lots of refined, processed foods, extra added sugar. Sugar is really inflammatory and toxic to our body. So we want to be starting to say, we're not going to be doing this except it's my birthday or it's a special occasion. We want to get away from dessert every night or a lot of the, I'm going to grab these protein bars on the go. And we really want to be focusing on what is both good and optimal. Diet high in fruits and vegetables, lots of fiber, lots of vitamins. We want to be taking that prenatal vitamin no matter what, because it can prevent birth defects. We want to look at getting enough sleep. And this is a place where we want our body to be convinced that it's a good time to reproduce, is how we think about how our bodies are made. If it's a good time for you to raise a child, you're getting enough sleep, you're getting enough nutrients, and you're able to move your body. And you're not as stressed as many of us are in our day-to-day life. Does that mean pregnancy can't occur in those circumstances? No, of course it can. But if we're saying, hey, I want my journey to be as easy as possible, or I want to control the factors I can, then we think about this very holistically, saying, hey, yeah, if I have enough resources for my body to work out and go to sleep and cook broccoli at dinner, then my body is going to feel like it's a good time we can raise another human. And we really want to approach this as on most of the days, we want to make most of our decisions really with a health focus in mind. And that doesn't mean we're super restrictive or that we never can do certain things. But if we are living very anti-inflammatory most of the time, then we're going to be able to tolerate these inflammatory exposures, both that we control and that we don't, and recover from them much faster because we have set a good foundation for how our body functions. And that goes for both eggs and sperm. So often I see one partner is focused on all of this and the other partner is just doing their own thing. And I really say fertility is a team sport. When it comes to now we're ready and we stopped our pill, now what? Or how long should it take? If we have somebody who's under age 35, we have about a 20% chance of getting pregnant per month. That means you may not be pregnant in month number 1. You may not be pregnant in month number 2. But by 6 months of trying, over 70% of people will be pregnant. So after 6 months, you're starting to fall into the minority. By 1 year, if you're under age 35 and you've not gotten pregnant, now you've formally been given the diagnosis of infertility, meaning it is time for a fertility evaluation if you've not had one sooner. I am a proponent of fertility evaluation sooner. If you have any abnormalities, so all the things we talked about before, spotting, abnormal bleeding, irregular cycles, pain, or if we have something medically with us that might make it harder to get pregnant, you can always get a fertility evaluation sooner. I'm seeing more patients reach out after about the 6 months of trying, say, hey, we would like to see some fertility testing. I love this because at this time, we're just checking. If everything's normal, we'll have a discussion. And it might be, hey, we're going to keep trying a little bit longer because we haven't met that year mark, but we feel pretty good that there's not something just absolutely preventing this from happening. And if it doesn't happen, we then have our game plan, or it gives you the opportunity to accelerate if something is detected earlier. But by that 1 year mark, you really should know. And meaning, if it hasn't happened by 1 year, please don't wait 2 years or 3 years or 5 years. Or this morning, I saw a couple who'd been trying 10 years. If it hasn't happened by that 1 year mark for sure, then we want to see you in and we want to get checking. And just quick note, that 6 month recommendation is for sure if you're 35 or older. So we don't want those patients to wait a full year just because of the age-related changes that we see with fertility. Outside of that, what? Semantics of getting pregnant. Sperm can live in the body for up to 5 days. An egg can live for 24 hours, meaning we need sperm there before or during the egg's course because the egg is so short-lived. This is why you'll hear us say that the fertile window is the 5 days before and then the day of ovulation. If you know when you're ovulating, great, have sex in that interval. If you have perfectly regular cycles and you ovulate on day 12 every single time, you can say, awesome, I'm going to have sex the 5 days before and the day of. If you are a couple who has intercourse every single day, have sex every day and you're fine. If your cycles are regular, you're hitting ovulation, you don't need to overthink it. You never need to have less intercourse if you're trying to conceive, unless you're going through fertility treatments and we ask you to. That's obviously a separate situation. If you are a couple who has sex 2 to 3 times a week or every 2 to 3 days apart, and that's pretty standard, same thing. Sperm lives long enough. It doesn't exactly matter when you ovulate because you're putting sperm there when you have an egg come. It will happen. So if you're having intercourse that frequently, then you also don't need to overthink it if you're having regular cycles. You are trying. If you are a couple, like the majority of couples have less intercourse than that, and that's totally fine, right? How much sex you have is a personal preference. There's no one answer that's going to work for every couple. But it's specifically the couples who are having less intercourse that we really want to look and time and make sure that we're putting sperm there as close to ovulation as possible to give them the highest chance of conceiving. Because we've seen studies before where people who are not sex everyday people start trying to have sex every day, and they'll start at the beginning of their fertile window. Let's say they start having sex every day around day 8. By the time they get to day 14 or 15, they're kind of burnt out on that because that's not what's normal for them. And then they're not having intercourse close to ovulation. That's where some of this recommendation of every other day in the fertile window or the day before the day of ovulation. But I think that we've done a bad job of stressing too many people out about it. Mm-hmm. I love tracking your cycle because it's giving you data about your body. If we think about a normal cycle, we'll talk a lot about day 1 to day 1. But the truth is there's a lot of nuance in the follicular and the luteal phase. And abnormalities like a short luteal phase or a short follicular phase can actually point to other problems going on that is at first stage of an ovulatory issue. So if you know when you ovulate, you're better suited to say, hey, my luteal phase is 10 days and Dr. Crawford said it should be closer to 14 days. Maybe there's something going on here and get that evaluated. So cycle tracking to detect ovulation is most helpful to understand if your hormones are functioning appropriately. And it can also be utilized to time intercourse, but it's not a requirement to get pregnant, meaning many people have sex unprotected frequently enough that they don't have to know, oh, let's have it. Today's the day, honey. Let's have sex today and put all this pressure on it.
Yeah, I think the pressure of it, and when people know that you're trying to conceive and are asking questions, like there does become so much stress. I mean, Dom can talk about my own experience with it too. But I also want to talk about the maternal age, because you brought up, prior to 35 and after 35. And we live in the after 35 boat, and so many of my friends do nowadays. So what really does happen after the age 35? What are we looking at, and what changes do we need to be aware of?
Jen, great question, because so often I see women come in and they say, well, I'm healthy and I'm still having periods, so I'm fine. My age doesn't matter. We really have to know that getting pregnant obviously is multiple different things. There's sperm, there's eggs, there's our body. But when it comes to eggs specifically, there's both egg quantity, how many eggs we have, and there is egg quality. And quality is really what is starting to impact us the most after age 35. Meaning, yes, you'll have less eggs at 35 than you did 30, but very few women are out of eggs at age 35. Meaning it's not the number of eggs you have remaining that starts to become a limiting factor for the vast majority of people. It is the quality of our eggs. And the way I like to think about this is that your eggs are inside that vault in your ovary for your whole life, and they absorb the wear and tear of everything that you're exposed to. And eventually we start to see breakdown in the functionality of our eggs. And there's two buckets that I like to think about egg quality in. One is going to be genetic normalcy. Our chromosomes in our eggs are in a certain position. They're like kindergartners in a line, is what I always say. The longer I ask them to stay in an alphabetical order, the higher the likelihood somebody's going to get out of line. And to put it simply, that's what's happening, right? More of them were in line at age 30 than at age 35 than at age 40. At age 35, about half of our eggs are genetically normal and half are abnormal. That's a pretty startling factor for most people. That's why we see the odds of getting pregnant start to drop, meaning if you're starting to try for your family for the first time at age 35, we expect that you're going to have about a 12% chance of pregnancy per month. That's not zero, but that's much lower than the 20% that you had at age 30 if you were starting for your family at age 30. It's still much better than the 5% that we see for women who are age 38 who are trying for the first time. So the decline starts to become quicker and faster, a steeper drop in what is left remaining normal after age 35. To be honest, after 37, it becomes more profound. So I don't want somebody who's 35 or 36 to freak out. But the reason why we put these shorter timeline on is because you need to be paying more attention. You don't have as much time to play with. We want to make sure we're getting to a diagnosis or getting you in for treatment sooner so that you can still have the outcome that you want. And especially for my couples who are looking to have more than one child, because we have to not just think about right now, we want to think about that future baby too. In addition to genetics is what I will call the metabolic quality of our egg, meaning our egg also has to be able to accept a sperm. And then division of that early embryo is all about the egg competency. So how the mitochondrial function, and does it have the right metabolic capacity? And some of this is where we can impact more of our egg quality, not all of our egg quality, but more of our egg quality based on the choices that we are making when it comes to inflammation in our lifestyle. I don't ever recommend that we delay something. I don't want to delay getting pregnant. I don't want to delay IVF so that we can, quote unquote, work on our egg quality. But it is something that absolutely should be done in tandem. And the perfect world is done before. Like we talked about earlier, this is something, I'm hoping we're going to have a new generation of people coming up that have been focused on health and longevity and these healthy habits, and really living a more anti-inflammatory life than we did when we were younger, and that we're going to see this tide turn. But the way that, infertility rates are changing, that where sperm counts are dropping, egg quality is dropping, this is all tied back to inflammation and this inflammatory, not just world that we live in, but lifestyle that we tolerate. We don't even think certain things are abnormal. I talk to every patient, and so many of them get 6 or 6.5 hours of sleep at night and just think that it's normal. That's all I need. I don't need more. but they do need more. Their body needs more. That's when your body heals from inflammation. That's when your hormones reset. So I think we have just really, as a society, allowed ourselves to think that these very toxic behaviors are normal, and we're starting to pay the price.
But now,
Totally.
often many of those people who are getting the 6 hours of sleep are also the people who are up at 5 a.m. hitting that rowing class or the Orange Theory or whatever it is,
and then workout, and they're burning,
and then going
calories.
to work a 10-hour shift at their high-strung, high-stress job, and then coming. It's like
yes,
everything.
and they only drink coffee during the day, and they're not eating food because they're so busy. Then they're binging on food at night because they're so hungry. And this is not a place where your body is convinced that you're in optimal health.
But because they're succeeding in all of those things, and they're fit and they're doing well in their work and they're showing up for everything, they're perceiving I'm healthy and I'm doing well in life. And I think that's a huge issue. Can we talk about, Jen first gave me a permission to tell our story. We've been very, very fortunate in conceiving. It happened very quickly, especially we've had 3 pregnancies, 2 beautiful little boys, and experienced 1 loss of pregnancy. But our first 2 pregnancies, it was like first time. We're like, okay, we're going to start trying. And then Jen's like, holy shit, I'm pregnant. Like it happened. And then the 3rd time comes around and Jen's like, all right, let's start trying. Didn't happen the first cycle. And she's like looking up the numbers for fertility clinics.
No, I'm not.
And
Not
like,
that soon.
It wasn't that dramatic.
But it becomes a stressful thing in your mind. It's hard not to.
And like Jen said, like she's past that 35 age mark, and it's like, when do we go in? When do we check? I'm like, let's give it a couple more months. Like we're good. But just the reality of the stress of, we fortunately haven't had to experience that, like trying for 5, 6, 7 months. But I can only imagine based on how she felt after 2.
I'm so glad that you guys are able to have success, but I think this is a shared experience where when we are not having success, we do start to really internalize what's wrong with me, what is happening, and we start to become stressed. And then I have patients say, oh, I'm stressed about being stressed. I mean, I think that we have to understand the stress response is a body's natural protective response from very bad things, right? Because it wants to keep you alive in times of war or famine and these other, a bear coming after you, right? So your body has a stress system in order to keep you alive, but we live in chronic stress, which is so different than all the acute stress that our body might be wired to handle. When it comes to trying to get pregnant, it is a stressful process, especially as we get older, and we can start to have that work against ourselves. And that's why I usually say it's important to actively work to decrease your stress, right? You might have a stressful job. I take care of a ton of patients who have really, really stressful jobs. That maybe is not where we're going to move the needle. If we're doing IVF, I might say, can we cut down? Can we give a project away? Can we take time off if we have to? But if we're just looking at, I have a stressful job, but I want to get pregnant. Maybe the job, you're not going to change it, but what else can you do? And we're all different. And this is where you'll hear people say, you need to meditate, you need to do acupuncture, you need to go to yoga, you need to do this. And what works for me is probably not going to work for Jen. We have to acknowledge that in order to get that release of cortisol, really that kind of benefit, we have to really look inside and know what we're going to benefit from the best. So is that going to be, I'm going to step outside, put my feet in the grass. I'm going to, go for an evening walk. I'm going to journal. Maybe it is meditation. Maybe it is therapy. Maybe it is acupuncture, but everybody's going to be a little bit different. I tell people you've got to seek out at least 20 minutes a day for you. And that's no phones, that's no emails. And think about, how do I tell myself that in all the minutes of the day, I can at least carve out these 20 to give to me and help me. But I think it's true. It's not uncommon to say, it's worked the first time. Why is it not working now? Mm-hmm. And secondary infertility is real, meaning as we age, there are higher risks that things won't go right, even if they've gone right in the past, because things like endometriosis and adenomyosis, those are increasing prevalence with age. Autoimmune disease, that increases with age. We see complications sometimes from prior births. I just had a patient who gave birth 2 years ago who's had infertility, and it turns out she had scar tissue inside her uterus from placenta that was left behind, and she had no idea. So there are things that put us in a different position when we're trying for a subsequent child that make us think, oh my gosh, what's going on?
Mm-hmm.
I again say, hey, that's where if we just keep this blanket, most people will be pregnant by 6 months. So don't freak out if it's not month 1 or 2, right? Not every egg is going to be perfect. You can be doing everything perfectly, but there's factors you can't control. But if we're getting to 6 months, then we can say, well, most people would be pregnant by now and we are not. So is this the time that we need to go get an evaluation? And I've never had anybody say, oh, I wish I'd made all those lifestyle changes, later. No, earlier you can make those things and be more proactive is going to put you in a position of power and feel more in control of a process that feels very out of control. I think that's one of the hardest things that people with infertility experience. And I had infertility. I had 4 pregnancy losses before I had my kids. And Jen, I relate to you. I internalized everything. What did I do wrong? What is happening this month? When do I get help? I got gaslit by my own provider saying, just keep trying. Oh, you're young. So I think we experience all of that, but keeping an eye on the fact that nobody's going to advocate for your health like you are. If your body is giving you red flags, listen to it. You know your body the best. If your doctor dismisses you, go see a new one, right? You can see another provider. If you know things are not normal, if things are not right, then stand up for that and try to get to that answer. And you can always have testing done. If you'd called me after 2 months of trying, we would do testing. I would tell you everything's normal and you would get pregnant afterward, and that's fine. But sometimes we need that, and that's okay too. Yeah. I really wish we were living in more of a preventive world with fertility instead of a reactive world. I'm hopeful that discussions like this, we're going to start to see that tide change. But right now, it is still a reaction. You have to fail, quote unquote, first before we're able to test to see if something's wrong. And that's just mind blowing to me, really, right?
Yeah. It's really sad. And I do want to, I know there's so much that I wanted to talk into, but I wanted to just hit on, we brought up miscarriages and we brought up loss. And that is a super incredibly hard thing that women go through. So many women go through, 1 in 4. So is there something that we could do that reduces our risk of miscarriage at all? Or what can you tell women that are going through that?
The top cause of miscarriage is random aneuploidy, which means the kids got out of line and you had nothing to do with it. So if we look statistically, that's the top cause. That should tell you that you didn't cause your own miscarriage and that there's really very little you can do except continue to try. With that being said, there are certain circumstances where miscarriages are more likely that I think it is important to know about. So if you have autoimmune disease, if you have any, uterine abnormalities, so you may not know if you have that, but if you're like, oh, I've had this weird spotting or bleeding or pain in the past, and now I'm having miscarriage, those two things might be connected. I always say the world's going to make sense. It's just we have to sometimes be the one to connect the dots. After 2 pregnancy losses, we recommend that you get an evaluation. 85% of the time, everything will be perfectly normal. We're trying to catch the 15%, and we can make a difference in those. In the others, we'll talk game plan, and maybe you keep trying on your own. Maybe we accelerate. At the end of the day, IVF with genetic testing can help determine which embryos are genetically normal, if that is what we're left to with miscarriage. I think that there's a lot of miscarriage that is due to inflammation also. I mean, that was my case. I ended up getting diagnosed with celiac disease more than a decade after I had my losses, despite being told that everything was normal. And I think that there's a lot of diseases that fall into that, quote, inflammatory heading. We see more miscarriage with endometriosis, with PCOS. And so those are also diseases that can take, right? Endometriosis can take 7 to 10 years to get diagnosed. So I think that when we look at a lot of this, it's not an uncommon experience to have pregnancy loss. We usually say 1 out of 4 will have a pregnancy loss that increases significantly as you get closer to 40 or older. But that should tell you that one loss can happen. And I don't want people to think, oh my gosh, something's wrong with me because I had a pregnancy loss. Because not every embryo is going to have the genetic or the metabolic competency. It's just not going to be the case. But if we're starting to have that happen more than once, especially if you're young, that's the thing to me is I often see patients dismissed because they're young and they're told, you're young, it'll happen. But to me, why is somebody young having miscarriages? Are we really saying that this young person has aneuploidy or abnormal genetics, which we usually associate with age? So what I might say is normal for a 39-year-old would be very abnormal for a 29-year-old to experience.
Mm-hmm.
And I think this is where we sometimes miss the boat to make the biggest impact, is that if the younger you are, if you're having pregnancy loss, if you've had 2 pregnancy losses or more and you've not gotten an evaluation, please ask your doctor. That recommendation has changed. It used to be 3, and I'm glad that the number dropped to 2. Many of us were clinically saying, I'm not going to make you lose a 3rd pregnancy before we do testing, even if most of the things might come back normal. In case we can find something, let's act on it. And especially if you have pregnancy loss, but we'll say if you have infertility in general, know your own story when you go see the doctor. I can only work with the information a patient gives me. I wasn't there. I didn't know. And I can tell sometimes we get nervous or, it's a lot to think through. It can be really traumatic, especially if we're thinking back through a lot of pregnancy losses to relay this information. But spend the time before your visit to, number 1, make sure your doctor has any records that have been done, any tests that have been done. Number 2, think through the timeline of what's been happening. Write it down or write down cliff notes. When did you start trying? How have your cycles been? What's been feeling off? How long did it take to get pregnant? How far did things get? Because the more concisely and accurately you can walk me through your history, the closer I'm going to get to be able to say, these are the tests we need and help us get to a diagnosis. So I can only work with that information that's given. And I think that's something we don't often think about before we go see a doctor, is how am I going to share what I've been going through in a really efficient way so that they understand what's really been happening to me and what I have sensed as not normal. You know your body the best. Be an advocate for it and make sure that you've kind of thought through what's been happening.
And I think it's just so important for people to hear that, because especially with miscarriage and loss, that can be something, especially if it happens multiple times, that people really start to internalize and take fault for. And that is not a place that you want to be in, especially if you want to continue that journey and continue to get to be pregnant. Finding ways to alleviate that stress that obviously will be looming if you continue that journey. So I appreciate you sharing all that. And I just appreciate you being here. And we have a list of like a dozen questions that we didn't get to amongst all the incredible stuff that we got to talk about. But I do know that you just came fresh off the press, came out with a new book, The Fertility Formula. So I know that you will probably talk about all of this and way more. In that. Where can people check that out or go get the book?
Thank you. Yeah, we're so excited. I'm so excited. The book is just such a labor of love that has been, over the past decade, everything that I've worked on social media and just been talking about, to really put it in one place that's progressively taking you through everything that we've talked about. So the Fertility Formula is divided into what I wish everybody knew about their body, talking about inflammation, your cycle, your hormones, your age, talking about your reproductive health. So tracking your cycles, whether you want to get pregnant or prevent pregnancy, all of the timed intercourse, what should we do? What should we not do? And fertility, how long is too long? What is testing? What does treatment look like? And then the second half of the book is all about lifestyle and how can we decrease inflammation with nutrition, with supplements, with sleep, with stress management, with exercise, environmental toxins, and putting it all together in a plan that I recommend. So I'm very excited for its conception story because it has been a long time coming, but you can find out more about the Fertility Formula at nataliecrawfordmd.com/book. You can pre-order it there. And I do have some goodies. So there is a 7-day hormone reset, kind of a fast track, easy version of the lifestyle plan. And then also access to the IVF course, which I've created if somebody's a little bit deeper in the process, because even patients who are going through IVF, I want them to focus on lifestyle, but also understand the process better. So I'm so excited that the book is coming out into the world. And thank you guys for having me on and supporting it as well.
Of course. I mean, you are a wealth of knowledge. This is going to support so many people. Clearly the resource to get if anyone is in this. I mean, you were all in the phase of life of trying to understand our bodies and be healthy more. So even if you're not trying to conceive, I hope that you want to get this book. I cannot say enough how much amazing information that you provide completely for free that people can look at as well. And obviously we're going to have that all linked up. I I love what you do. I appreciate it so much. And we really appreciated your time today.
Thank you guys so much. I really appreciate you guys holding space for this discussion and helping advocate for fertility and optimal health just in general. So thank you for having me.